Okay, so let's talk about pulmonary embolisms. This is part of your gas exchange um, concept. Also, it can include acid base imbalances and comfort as well. It is exemplar 16K if you want to follow along in your book. I highly recommend that you have your outlines so that you can follow along as I move through this, taking your own notes because those outlines are mine and you need to take your own notes. So let's talk about what a PE is. I like to say I've never met a PE that I have ever liked because I have seen a lot of PEs and a lot of patients have not survived their PEs. So um, we do see them. They can occur anywhere. You don't have to work in the ED or the ICU to see these. You can see them in the doctor's office. You could see them if you work in like a freestanding ER, minor emergency, on the floor. I mean, you name it, most patient populations as well. Okay, so I found a little JPEG. This is also in your outline because I didn't like the one in the book and I like a good picture. So fundamentally, a PE is a blockage of the pulmonary artery. It's a thrombus that started somewhere else, has moved to the pulmonary artery, flows through until it lodges and obstructs the perfusion of that alveoli. So it can be a thrombus. It could also be a fat emboli. From the number one cause for fat emboli are long bone fractures, like a femur fracture. Those can happen and they can kill you. That happened to somebody I went to high school with, actually broke a femur and died not long after high school. Or an air embolism. Most common reasons for air embolisms are probably discontinuing a central line, getting air in your central line, having air in a syringe when you're injecting a patient. So don't do that either. So the number one cause of a PE, where this thrombus is coming from, is a venous thromboembolism, VTE, or I will probably say DVT, deep vein thrombosis, because that's what I learned. So you know, I'm trying to convert over to VTE, but if I say DVT, same kind of thing. Um, so those are deep in the legs, femoral, iliac are most common. That turns loose in the vein, which is blood moving up towards our heart, moves into the right atrium, gets to the right ventricle, goes to the pulmonary artery where it wedges, and then we don't get blood flow, we don't get oxygenation. Um, can be in an upper extremity. I have seen this where it's been in some arms from immobility that causes that. I've seen it, patients come in with it. I've also seen it just occur in your patients in the hospital. If you've ever heard the term saddle PE, that's a large thrombus that's lodged at the arterial bifurcation. So it's two large branches. These are really bad. Um, so that gives you an idea of what this is like. So both perfusion and ventilations are impacted. We get some vasoconstriction, which leads to increased pulmonary pressure, so increased pressure in the lungs, which leads to pulmonary hypertension, and they have signs of a right-sided heart failure because that right side of the heart, you got to get your blood flow through the heart down, is having a hard time pushing blood into the lungs through the pulmonary artery because of this occlusion and the increased pressure. They also develop atelectasis. Whoop, went the wrong way. Sorry about that. All right, so let's talk about risk factors and preventions because this is fundamentally where we should be working. So, who's at risk? People who are immobile or have reduced mobility. So, you need to think of all the different types of patients this is. This could be somebody who's had surgery, who's not getting up and walking, because we all know that our patients after surgery need to turn, cough, deep breathe, and get up and walk and move around so that they don't develop pneumonia, atelectasis, and a DVT. So we all know that. This could be people who have reduced mobility because they've suffered an injury. It could be that certainly that recuperation from surgery. This could also be now the fact that people work from home, have desk jobs, and spend a lot of time just sitting, which is why the new trend is to get a workstation that you can raise your computer and stand, because we know that sitting compresses those vessels, makes it more difficult for blood to return to the heart, and just long-term sitting affects us in lots of ways. Surgery, certainly a history of VTEs, being overweight, use of oral contraception or hormones can make you more prone to having clots. Pregnancy and childbirth can do this. It is not it is not uncommon for someone who's pregnant to have a PE during, especially in the later stages of pregnancy, when they, that baby's grown and their uteruses are really big, so we have some compromise, we can have some compromised flow. So this certainly can happen. It can happen after childbirth. Cigarette smoking gives us increased risk. Atrial fibrillation. So when our patients are in atrial fibrillation, the atrias quiver, and when they quiver, the blood doesn't move through well. It tends to make what's called mural thrombi or mural thrombus, and if it's in the right atria, that turns loose and causes a PE. You should also have learned about the risk factor of atrial fib with stroke, because that's the clot from the left atria. And then certainly people with clotting disorders who are more prone to clotting. So what's the prevention? Well, this should not be that difficult when you go back and say, okay, let me look at all these risk factors. What do we need to do? You need to get up and walk, and you need to move around. If you're having clotting problems, then and we suspect you have a clotting disorder, then we need to go send you to a hematologist to let them deal with those sorts of things. We need to not smoke. We need to be aware that if we are on hormones or taking oral contraception, that increases our risk, which is why before you're prescribed that, your healthcare provider will look at the risks and benefits of those types of things. So we really do need to work at preventing this. The other thing too is, remember, the reduced mobility can be from people who travel. So whether you're traveling by car, plane, boat, all of those kinds of things, prolonged sitting can do this. Can increase your risk, which is why you need to stop every couple of hours, get out, walk around, move around, stretch, do some exercises while you're sitting. If you are going to be in a car and travel for, like all day long, be on a plane, maybe you're going overseas, so those are 8 to 24-hour flights, get some compression socks, wear those kinds of things. The other thing is also to hydrate as you travel, because that will help as well. Okay, so let's talk about clinical manifestations. I followed along in your book. It does a really good job that splits this between respiratory and cardiac and other. And I did include fat emboli, which you should have had previously, but it never hurts to kind of stick it back in your head. So what are we going to see respiratory-wise? Well, if we are plugging up part of their lungs, they're going to have respiratory problems. So they're going to have dyspnea. That's the most common symptom. It can be, they can have mild to moderate hypoxemia, so those O2 sats are going to be low. They're going to be tachypnic because they can't breathe, so they will be breathing rapidly. They're going to have crackles. They'll have pleuritic pain. It's sharp, knife-like, hurts more when they take a deep breath. Respiratory problems, cardiac problems can share some signs and symptoms. But pleuritic pain hurts worse when I take a deep breath, move around, is not, I'm having a heart attack pain. That tends, so we can kind of rule that piece out. They can have cough. They may have hemoptysis, so they may have bloody sputum. So if your patient gets short of breath, gets tachypnic, starts to cough, you're seeing signs of hypoxemia, they're talking about this pleuritic pain, you need to be concerned. They're going to be tachycardic. That is part of compensatory mechanisms. So is the tachypnea. Your body says, I'm not getting enough perfusion, whether that's based in my heart can't pump, which is why we get tachycardic, or it's a breathing problem. I need to breathe deeper. That's compensatory. They could have some syncope, so they'll have some fainting is losing consciousness. Sudden changes in mental status. That is significant. That is certainly not getting oxygenation to their brain, and they can be diaphoretic. When you think of PE, I know the book puts this under the concept of gas exchange, but you need to put and perfusion, because we're not moving blood flow as well. So that is an interrelated concept that we're going to have. Other anxiety, feeling of impending doom, because these patients come in, they say, I can't breathe, and it's bad, and it escalates, and this can move very quickly from minor symptoms, more symptoms, to I can't breathe, and I am coding, and the patient's lost a pulse, not breathing, and we're having to give them emergency treatment, and that can happen in the span of 10 minutes or even less. Fat embolism, sudden onset of cardiopulmonary and neurological symptoms, dyspnea, tachycardia, tachypnea, confusion, delirium, decreased LOC. Petechiae is the piece that's inherent to fat embolism. All right, so there is some specific criteria that we look at. We have tachycardia. Our O2 is less than 95% on room air. We have a history of PE or VTE. We have hemoptysis. They've had some risk factor like recent surgery or even trauma. They're getting cancer treatment. Being on cancer treatment is also a risk factor for PE, or they have unilateral leg or limb swelling. Because think about it, if your patient has a DVT, what does that look like? They will have and usually we see it in the legs, it will be tender, it will be red, and it will be swollen, and if it's on one side, you very much need to suspect a PE.